everybody. I'm Casey Peluso of Parkinson Foundation, Western Pennsylvania, and welcome all of you to the April, the Parkinson's Awareness Month Talk with the Doc with Dr. Timothy Leichliter of Allegheny Health Network. I will let him take it away. Thank you, everybody, for attending and supporting our programs. And thank you, Dr. Leichliter, for giving your time to us each month.
No problem. I'm going to mute everybody just one more time. So, Casey, I'm going to mute you too. All right. Welcome back, everybody. Or if this is the first time you've been here, welcome to the party. I'm Dr. Leichliter. I am a so-called movement disorder specialist sitting here in my office at Allegheny General Hospital. This is really a live question and answer session. So if you have questions, I've gotten some in email, which I'll start with, but type them in the chat box. That's ultimately the best way for me to get to, and I'll get to those ones after I answer these ones. The general caveats that I give people for this kind of a talk is that this is a general audience, a lot of people with Parkinson's disease caregivers, but not a one-on-one session. So again, this is not a great place to say, hey, I'm on this and this and this medicine, and this is my problem. What do you think I should do next? My answer is generally going to be, you should probably talk to your doctor, unless it's me, in which case send me a message on a different forum. The other thing I like to tell people is that everything you're about to hear is really my opinion. I have a lot of opinions, and I have no problem sharing my opinion, but it is nonetheless just my opinion. If you go to a different movement disorder specialist, or you go to a different neurologist, or you go to a different primary care doctor, they may have differing opinions. I like to think that I tell you as much scientifically backed opinion as I can come up with, but sometimes there isn't any science to back it up, and I have to make stuff up. I usually will tell you when I'm making stuff up. May even throw up some quotation marks to tell you I'm making stuff up, but I'll try to make that pretty clear. With that, I'll get started. And again, even if you think questions have been answered already, throw them in the chat box. Believe me, it never hurts to answer questions more than once, and everybody generally has all the same questions, so don't be afraid. All right, I'll start with some of the questions that I got in email. That's why I'm looking over here at my screen here. The first two are actually about articles. And so I don't know if anybody saw the article. The first one they asked about was about the article on gold particles. There was an article in something that suggested that gold particles were potentially neuroprotective or disease modifying in things like Parkinson's disease and other neurodegenerative conditions, which I read. And what I gathered from that article is that gold, particularly, however, I'm not saying you should go start melting down your rings and chains, but at the end of the day, however they were coming up with this gold product, it seems like it's a very powerful antioxidant. It seems to work on the mitochondria, which are the powerhouse of the part of the cells that really we think are impacted in Parkinson's disease. But nonetheless, it seems like a potent antioxidant. Again, a lot of the things that you'll read about or hear about over the counter, glutathione, CoQ10, turmeric, these are all thought to work on the mitochondria, on the antioxidant pathway. And like the article said, it's still early. I mean, they're still working on animal models. And if you've ever been to any of these meetings before and heard me talk, I'm as skeptical as they come. I don't get excited until I see actual good hard evidence. I need to see in people trials. I need to see randomized controlled trials. And generally, you don't get that with these kind of supplements over the counter or antioxidant type things. But I will keep my eye out for that one. Again, I think more to come. I think there's some science there, but I need to see actual good studies before we say, yes, this is a great idea. The second one was a little bit more interesting. So this was about a specific strain of gut bacteria that they were linking to, and how did they? Oh, scientists discover what causes Parkinson's disease. I really like that title. And the long story short is they found a certain strain of bacteria that seemed to be more prevalent in people with Parkinson's disease, and they thought that that could definitely be playing a role or potentially the underlying cause. Now, again, this is not unknown. We have known there's a link between the gut and Parkinson's disease for quite some time. We just haven't figured out what to do about that yet. So I'm interested to see where this goes. Questions that came to my mind when I was reading this is, how do you specifically isolate that strain and eradicate it? There are ways you can do gut bacteria transplants, or you can try to wipe out the bacteria that you think is bad and try to replace it with good bacteria. This is also where you start getting into probiotics and prebiotics to try to make that happen. But the long story short is I need to see a lot more evidence and stuff like this, how they can try to isolate that type of specific bacteria strain, get rid of it, replace it with good bacteria, and then see how that impacts either people who are predisposed to develop Parkinson's disease or potentially people who have Parkinson's disease. Does it actually slow down the course, alter the progression? I thought both of those studies were very interesting, or both of those reports were very interesting. And now I just need to see the follow-up. So I want to see what happens. I want to see how we take that to the next step. Again, I don't think any of that was really earth-shattering. I think it really just expounded on things that we already were relatively aware of. But what we always kind of run into is that we know that there's a mitochondrial problem in people with Parkinson's disease. We know that the powerhouse parts of the cells aren't functioning, and the energy that in the cells is problematic. And we know that the gut is involved. There was a study from, I don't know, I'm making up some sort of Scandinavian country. I forget which one. I want to say Finland, but I could just be making that part up, where they actually looked back and they saw that people who had had a selective vagotomy, which is you cut the nerve between the gut and the brain, were much less likely to go on and develop Parkinson's disease. And so we have known for a while that there is a connection there. We just haven't taken the next step to figure out how to use that to our advantage or what we can do about that. Again, I think at some point in the future, we're going to figure this stuff out. We're going to really get to the nuts and bolts about what causes it or what triggers it or where it starts. And that's really the first step in figuring out how to prevent it, fix it, and slow it down. And so I like it when you send me articles like this. And actually, the gold one I had already seen, the gut bacteria one I hadn't. But I like to read these things because I like to know what the state of affairs is in terms of where the research is heading. But I want to see more. I want to see more of the next step. How do we use that in patients? How do we use that to our advantage? And can we really find something that is disease modifying? Those are my general thoughts. Take them for what they're worth. All right. I've had passing out spells during exercise when my heart rate is up. I have had my blood pressure tested and I do not have neurogenic orthostatic hypotension. When I pass out, I vaguely remember and also freeze at the same time. Do you know what this may be? Not really is the short answer. Generally, when I see patients who are having syncopal episodes or passing out spells, it's blood pressure related. Again, blood pressure is not the only thing that can make you pass out, but it just happens to be one that's commonly impacted in people with Parkinson's disease. So when they refer to neurogenic orthostatic hypotension, what that means is when you go from sitting to standing, typically your nervous system should have mechanisms in place that prevent your blood pressure from going down. In fact, it should boost your blood pressure and your heart rate a little bit so that you can pump blood up to your brain and it doesn't all go down to your legs. Not that your legs don't need it, but your brain needs it more. And those mechanisms don't always work correctly in people with Parkinson's disease. This is when we start talking about the autonomic nervous system. And so neurogenic orthostatic hypotension is when you go from sitting to standing, those mechanisms don't work and your blood pressure goes down and you pass out. There are other things that can make you pass out. So irregular heart rhythms can make you pass out. Lack of oxygen can make you pass out. There are definitely other things that can make you pass out. And if blood pressure is really not the culprit, then you really need to work with your primary care doctor. You may need a cardiologist or a heart workup or a lung workup to really try to get to the bottom of this. Freezing does not usually lead to passing out. And so I would say it is distinctly uncommon. In fact, I can't think of a single patient who told me that freezing led to passing out. So I'm not sure how those things are correlated. And the only way I can tie that together is whatever mechanism is involved that's making you pass out is probably also likely causing you to freeze or your Parkinson's symptoms be worse. And that's why you're feeling that. But that I definitely think needs more workup. I'm not entirely sure I have a good explanation for that one. And I don't think that's necessarily a common story that I hear in the office. All right, can I give my opinion on the neuroablate system? Of course I can. I can give you my opinion on everything. And so what is the neuroablate system? So the neuroablate system is, we're talking about high frequency ultrasound ablation here. And I was just looking up kind of on their website if they said anything new. Anyway, at the end of the day, if you haven't heard, we typically think about a couple different procedures in people with Parkinson's disease. And now we're talking about more progressed disease or more advanced disease, things where medicines aren't doing all the things we want them to be doing. We're having trouble, we're running into difficulties. And this actually dovetails into the first question that I saw typed in there, which is, when do we start thinking about more aggressive things? First, there are two types of procedures that we do for people with Parkinson's disease. The first one is the deep brain stimulator surgery. So the deep brain stimulator surgery is invasive. It is aggressive. We drill holes into your skull. We put wires into your brain. We hook you up to a generator in your chest, and you have internal machinery. We've been doing deep brain stimulator surgeries for at least 20 plus years. Like, don't quote me on the number. I can't remember exactly how long it's been available, but it's been a long time, and we have a lot of experience with it. And it works fairly well for certain people. People who are good candidates for surgery are people who respond well to the medicine. We think that all of these types of procedures work for similar things the medicines work for. The medicines work better for tremors and stiffness and slowness of movement, and they don't work very well or as well for things like balance or speech or, cognition or thinking. And so these procedures work better for tremors and stiffness and slowness of movement, and not quite as good for the other things. And so the ideal person who comes in would be somebody who's relatively healthy, because these are still brain procedures, who has typical Parkinson's disease, who has had it for a couple of years, who has had good response to medications, but either we're ramping up the medicines or we're running into side effects of medicines, or there's issues like hallucinations or dyskinesias. They don't have a lot of medical problems. They don't have a lot of memory problems. They don't have a lot of balance problems. That would be the ideal person. The other procedure that is available or potentially able to be done is something called a high-frequency ultrasound ablation. Now, this is a new take on an old idea. So a long time ago, we learned, probably 100 years ago, we learned that if you put a hole in somebody's brain, you can stop them from shaking in some of these symptoms. Fast forward to probably 50, 60, 70 years ago, they learned that you could do it through radiation. You could do it through gamma knife. The old-fashioned version was they would cut a hole in your skull, they would put a probe in, they would burn a hole, freeze a hole, take it out. I think, although he's not my patient, I believe Michael J. Fox had that type of procedure done. I think he makes reference to it in one of his books. But that was the old procedure. We learned that you could do it through radiation, so that's when stereotactic radiosurgery or radiating a small hole became a thing, but that was about the time DBS became a thing, so we kind of scrapped the idea of putting holes in people's brains, and we started putting wires in people's brains. Fast forward to about 6 or 7 years ago now, they learned that through MRI guidance, you can focus ultrasound waves in a certain area, and you could burn a hole in somebody's brain. The benefit is it's no drilling, so there's no holes in your skull, there's no internal machinery. They can externally put a hole in your brain. I don't say it's non-invasive. You still end up with a hole in your brain. But it is, in my opinion, less invasive than, say, deep brain stimulator surgery. Traditionally, or up until fairly recently, they could only do one side. Now they are doing both sides. But at the end of the day, I kind of compare and contrast these two. So when I'm thinking about deep brain stimulator surgery, it is much more invasive. It's more aggressive, but at the same time, there's multiple contacts or kind of stimulation sites on each wire. And so it's adjustable, it's controllable, it's steerable to some extent. And you can adjust it over time. So if symptoms become more problem, you can increase stimulation. If there's a problem, you can decrease stimulation. We have a lot of experience with this. A lot of times people are able to cut down their medicines, although that's not the goal. And so there are a lot of pluses to it. On the counter to that, the high frequency ultrasound is a little bit newer, but I still have some experience with it. It's much less invasive. Again, there's no holes, there's no internal machinery. But at the end of the day, it's not really adjustable. At the end, you have a hole in your brain. And if it controls your symptoms, great. If it doesn't, you can't really change that fact. And there's not much different you can do to make it bigger or adjust the location, things like that. Now they are starting to do both sides. They still do one side first, and then I think 6 months later, they bring people down to do the other side. Probably the biggest downside for me is I don't have that technology or availability in Pittsburgh. The closest one is West Virginia University. The other one is Cleveland Clinic. I've been told UPMC is getting one this spring, but I haven't heard anything about that. I keep asking for one here at Allegheny Health Network. I keep getting shot down, but I'll keep ringing it up. But those are kind of the two more aggressive or invasive procedures that we do. Not everybody's a good candidate for those things, right? I mean, at the end of the day, if you have a lot of memory problems, we certainly don't want to go drilling holes, burning holes, or putting machinery in you. It can make that worse. If your main problem is walking imbalance, that can sometimes be made worse by doing procedures. And if the medicines really aren't effective, then I'm much less confident that doing any of these procedures is going to be all that helpful. And so, again, it's definitely a very individualized approach to any of these types of procedures, but in the correct person, in the correct setting, they are really useful. And so it's my job to talk to my patients about all of these choices and explain why they're good or why they're not good, or why I think this is what we should do, or why I think that's what we should do, and have a conversation about it. I never talk people into surgery. I'm not a surgeon. I'm as the opposite of aggressive as they come. I am not eager to get people to the operating table, but if it's necessary and if I think it's the right choice, I will absolutely be getting you to the surgeons. And as long as people are aware of it and have thought about it and we can have a conversation about it, that's the best way to approach it. So if you're not my patient and you're wondering about these things, you really should talk to your doctor about it and talk about the pluses and minuses, the pros and cons. Everything comes with a price. There's no such thing as free magic, and these are no different, but the medicines come with a price too. And so you have to keep these things in mind when you're trying to figure out the best plan for you. Long story short is have a conversation with your doctor, with your neurologist, with your movement disorder specialist, talk about all of these as choices and figure out what makes the most sense for you. Have I heard of the new skin test for Parkinson's disease? Yes, I have. In fact, we just started doing these here. Much like the spinal fluid alpha-synuclein test that you heard about last year from the Michael J. Fox Foundation, which is also starting to, I think, become a little bit more commercially available, although I haven't been able to find that yet. There is a skin biopsy that also tells us some similar information. It's a series of 3 biopsies. I think they do shoulder, they do somewhere else. I can't remember offhand. My nurse practitioner knows, but at the end of the day, there's a couple different places that we do, and based on the pattern, it does tell us whether or not we think you have some sort of alpha-synuclein problem or Parkinsonism, and maybe it can even distinguish between some of the Parkinson's plus conditions. But I liken it to similar information that I would get from a DAT scan. So a DAT scan is a dopamine transporter scan. I don't do these scans or these tests in everybody, but I do use them to get information that I
On the
need.
kitchen counter. Just tell ML I'm resting and everything went fine.
If I can get more information, then it helps us decide what to do next. And so that's where you'll see me use scans. That's where you'll see me use biopsies. Eventually, you'll see me do spinal taps. That's where we'll do these things, because the more information that I have in certain situations, it does change my plan. I don't need these tests in the vast majority of people. Again, the diagnosis is still made clinically. It's still based off of what I see, what you tell me, what I hear, and how you do when we start treating you. And that's not going to change based on these tests, at least not just yet. But in certain cases where I'm unsure what's going on, or I don't know what I'm going to do next, do I just ramp up the medicines? Do I backtrack and go a different direction? That's where you'll see me start using some of these ancillary tests. And that's where I think they have use, at least currently. But you are going to see more and more of that, because more and more are coming. In fact, I'm trying to get hooked up with a local ophthalmologist so that we can study tears in people with Parkinson's disease for a very similar thing, is that maybe there's some markers there that might give us some more information. Can I please review the distinctions between Parkinson's and Parkinsonism as related to diagnosis, treatment, and prognosis? Yes, I can. Okay. This is important, and I actually just had this conversation as a presentation to a lot of internal medicine doctors. And again, everybody's going to view this a little bit differently. So this is my opinion that you're about to hear. I do not use those words interchangeably. There are a lot of people out there that do. There are a lot of people that if you come in with tremors and stiffness, you have Parkinson's disease. I may not say that. I really do use the word Parkinson's disease to mean something specific. In my opinion, Parkinsonism is the symptoms. So if you have tremors, and if you have stiffness, and if you have slowness of movement, and if you have balance problems, you have Parkinsonism. Parkinson's disease just happens to be the most common cause of Parkinsonism. Parkinson's disease is all of those symptoms in the setting of no good explanation or cause, typical onset of presentation, typical progression, response to medicine, so on and so forth. Everything is fairly typical. If you are typical, then I label you with Parkinson's disease. If you are atypical, meaning you're not the right age, not the right presentation, don't have a good response to medications, there's some underlying trigger that explains your symptoms, then I would not call you Parkinson's disease. I would call you Parkinsonism. If there is a cause, let's say there's a medicine that I think is causing your Parkinson's symptoms, then I would call that, drug-induced Parkinsonism or medication-induced Parkinsonism. If I do an MRI scan and I see a lot of vascular changes, then I would label that as vascular Parkinsonism. But a lot of times things are just atypical. The Parkinson's plus conditions are also Parkinsonism. So again, anything that has those symptoms is really a Parkinsonism. That I use, I do not use those words interchangeably, and I really do select a specific group of people to label with Parkinson's disease. And I do that for one very important to me reason. If I'm calling somebody Parkinson's disease and they're typical, then I have a really good idea of what I think is going to happen to that person as they progress with the medications, and I can give them a fairly good understanding to some extent. I'm not a wizard here. To some extent, what I think the future looks like. If anything is atypical, or I label it as Parkinsonism, it means I'm not sure. And then I'm much less confident in knowing what's going to happen, or knowing how you're going to do when I give you medicine, or knowing what the next steps are going to be. The end result of what I do in terms of medication choices, therapy choices, harping on you about exercise probably doesn't change. But my knowledge or ability to guess the future is a lot better in typical Parkinson's disease than it is in Parkinsonism. That's why I use those words differently, and that's why they are not interchangeable to me. However, somebody down the road may label somebody with Parkinson's disease, and then they come to me and I say, no, I think this is Parkinsonism, or vice versa. We all don't have the same necessarily exact definition of these words. We all have something in our head that we use for these kind of words and how we use them. And I think movement disorder specialists are probably more selective in how we use the words compared to a general neurologist or a primary care doctor. And so you do have to be careful and take everything with a grain of salt. But that really is the distinction, in my opinion, and where you'll see me use those different diagnoses or words to try to explain what I'm thinking or what I'm seeing. We're getting there. Couple more in the email. Do the majority of my patients have sleepless nights? My husband is not able to sleep more than 4 hours on and off during the night. Do you think this is because Parkinson's symptoms are not controlled enough at night? He does take one extended release around midnight, then another around 4. He's tried melatonin. The short answer is yes and no. So a lot of my patients have sleep problems. Sleep problems is very common in people with Parkinson's disease, and it runs the gamut from REM behavior sleep disorder, which is acting out dreams and nightmares and punching and kicking and throwing yourself out of bed, to just insomnia or not sleeping well at night or waking up in the middle of the night or having urinary frequency during the night. And so the hard part about sleep problems is it's quote unquote multifactorial. And trying to get to the bottom of it is difficult because there's so many different things that play a role in sleep. It could be that his medication's wearing off. I have a lot of people who take pills every 4 hours during the day, and then sure enough, 4 hours after they go to bed and take their last pill, they wake up and wonder why. And I say, well, guess what? Your pills wear off at night too. Let's try switching it up or changing it up. So pills can definitely wear off overnight, and often that does wake people up. Urinary problems are very common in Parkinson's disease, and urinary problems often flare up at night due to how your kidneys function. And so that wakes people up at night a lot. Acting out dreams or vivid dreams or things like that also wake people up. And trying to get to the underlying roots is very, very difficult. It is not an easy thing. I'm going to want you to try, especially if we want to try to figure out how to work on this, but it's not always easy to do. But the short answer to the question is yes, a lot of people have sleepless nights, and you either have to try to work around it by sleep medicines like melatonin or Seroquel or Remeron or Klonopin, or there's a slew of medicines that Trazodone we use to try to help people sleep, or we need to try adjusting the levodopa to see if that covers you better during the night, and maybe that's why. Maybe we have to work on urinary symptoms. Trying to get to the underlying cause definitely helps us try to fix it, but I will promise you it is not easy to try to come up with the why in terms of why people have sleep problems. But yes, the short answer is it's very common and a difficult problem for us to work on. Can I explain how pramipexol works? Well, yeah, I probably can. I take a bunch of Cinemet. I also take some Mirapex. Didn't notice any changes right away with starting the Mirapex, but now I'm doing better. Great. Sounds like a great idea. Just wondering if my improvement is the result of Mirapex. Maybe. So there's a lot of different classes of medicine that we use for people with Parkinson's disease. Now, carbidopa levodopa is the gold standard drug. That was invented back in 1968, I don't know, somewhere in the late 1960s. I can't remember the exact year. And so it's been around for a long time, and it is still the gold standard drug that we have. It is as close as we can get to replacing dopamine. Turns out a long time ago, before we came up with this, we tried giving people dopamine. Once we figured out we thought that was the problem, it didn't work. But it turns out if you give them levodopa, which is the step before dopamine, which is somewhere on my board behind me here, it does get to the brain, it gets converted into dopamine, and people felt better. So that's still the best way we have to try to replace dopamine in the brain. It's not, the carbidopa levodopa is not directly dopamine. It is levodopa, which means dihydroxyphenylalanine, which is the step before dopamine. It gets converted into dopamine. All of the other medicines that we use work differently. Now, there's a bunch of different varieties of carbidopa levodopa, and they all work relatively the same. But the other medicines, including pramipexol, which is Mirapex, work differently. So Mirapex, Requip, Nupro, Xadago, no, apomorphone. These are the so-called dopamine agonists. And so what they do is, instead of working to replace dopamine or be the precursor to dopamine, they activate dopamine receptors. And so my simplified brain, because I can only handle things in simple fashions, is that it's like synthetic dopamine. Instead of kind of correcting or replacing the chemical that's missing, it activates the receptors, which is what dopamine does anyway. And so instead of going through the pathway of trying to increase dopamine in the chemical, it just jumps straight to the other side and activates the receptor. So it's a very simplified mechanism of how Mirapex works, but that's theoretically what it does. And then you have other medicines like entacapone and opicapone, which are COMT inhibitors. COMT is catecholomethyltransferase, is a chemical or an enzyme that breaks down dopamine. And so if you can block the breakdown of dopamine, it hangs around longer, helps it work a little bit longer. Same thing is true for rasagiline, selegiline, safinamide, which are the monoamine oxidase inhibitors. Monoamine oxidase also breaks down dopamine. And so the long story short is all of these medicines either directly increase dopamine, keep dopamine around longer, activate the dopamine receptors, but they all work differently on the same chemical and pathways. That's how pramipexol works, and that's why we use it. And that's why you will see us use multiple different types of medicines, because I think there is something to be said about rational polypharmacy. Now, if you go to your primary care doctor and you say, I want some polypharmacy, they're going to say, nope, that's a terrible idea, because primary care doctors have been trained. You should really maximize one drug before you throw on another one. That's generally the best way to do it for things like blood pressure, cholesterol, diabetes, so on and so forth. In my world, it's a little bit different. We know that the higher you ramp up the dosages of carbidopa, levodopa, or Mirapex, or any of these drugs, the more problems you run into, the more hallucinations, the more dyskinesias, the more wearing off, the more fluctuations. And so if you strategically try to keep all of the dosages low by layering in multiple different medicines that work differently, but together, sometimes you can get better results. Now, again, across the board, you'll almost always see us start with carbidopa, levodopa. It really is the best drug we have. But after we take it up to a certain spot, almost across the board, we will all be layering in different medicines, because they really do work differently and they work together. That's kind of the long and short of the mechanism of action of these medicines, but just get the idea that they work differently. They are not the same mechanism of how they work and how they try to get you doing better. And that's why you'll see us use combinations of drugs to see if maybe they work better together as opposed to just ramping up one. All right, let me scroll back up here to the top. All right. When is DBS advisable? So this is what I was referring to. It is very, very individualized. At the end of the day, you really have to have an individualized conversation going over the pros and cons, the risks and benefits, and really talk about why it would or wouldn't be a good idea. Generally, we like people to have Parkinson's disease, specifically Parkinson's disease, not one of the Parkinsonisms, for a few years. We don't like to do it early, although in Europe they are more aggressive, and they've done some early stimulation trials with some benefit. So whereas it used to be we like people to have disease for more than 5 years, now it's at least maybe 2 to 3. But again, all the other things that I talked about early apply. But it's not for everybody. And this is where it really becomes a conversation. And I would say it usually takes, from the time that I first bring up the idea of deep brain stimulator surgery or even high frequency ultrasound ablation or anything more aggressive, it's still a good 6 to 12 months before the patients have learned enough about it. We've talked enough about it, and we're both on the same page. We say, okay, let's get you the surgeons. It is not something that I just bring up and we're like, yep, let's do some brain surgery. And so it really is something that you want to have conversations about. I don't like this question. I'm going to pass. What occurs if I do not exercise? We're not going to find that out because at the end of the day, you're going to. I should say you die instantly, but that's false. I made that up. Scare tactics don't always work. In fact, they usually don't work. In my experience, if you don't exercise, you progress quicker. End of story. You do not do as well. You progress quicker. You need more medicine. You fall more, and things do not go well. That has been my experience over the past 10 years. And the people who exercise the most do the opposite of that. Again, that's not proven. They're still working on showing that exercise is in fact disease modifying, although I definitely believe that it is. That has been what I have seen time and time again. And I feel like if you ask that question to anybody, this has been the experience of everybody. Everybody that I've ever talked to in the movement disorder world agrees that exercise is the best medicine for this. It is the only thing that is potentially available currently that is disease modifying, although not proven. And so realistically, my answer to that question is if you don't want to exercise, I can't make you exercise. I'm not going to come to your house and make you do it. If you don't want to exercise, that is a God-given right and choice. But I really don't think you will do as well as you can. And I think you will see other people who are exercising do better than you. So let's just not figure that out. Let's not test that theory. Any tips on bedwetting at night for somebody with Parkinson's and Parkinson's-related dementia? Are there medicines that are helpful with this? Yes and no. Again, urinary problems are big in Parkinson's disease with or without the dementia aspect of this, but definitely more problematic in people who have cognitive problems and dementia along with it. And it's tough for a lot of reasons. One is in Parkinson's disease, because the autonomic nervous system is impacted. That's the part of the nervous system that does control going to the bathroom. Again, when you got to go, you got to go. It's almost like instantly, if I don't go to the bathroom, I'm not going to make it. And then again, you superimpose that on somebody who doesn't move very fast. Again, they can't get to the bathroom. And oftentimes, even at night, they don't even wake up. They just have accidents, things like that. There's a couple of medicines that I'll try. I'll try things like oxybutynin and Vesicare or Ditropan. I can never remember which one's which. There's a couple of medicines that I'll use. I've seen urologists use things like Myrbetriq. That's not a medicine I'm great with, but realistically, I often send people to urology to see if there's anything else that can be done. And I would say the medicines are helpful some of the time, but not all the time. Again, much like a lot of these non-motor symptoms, they're hard to fix and they don't respond as well to medicines as we would like. But if you brought it up to me and we were trying to do something about it, those are the medicines I would probably throw at you. Again, you do have to at least be aware of or think of that, any of these medicines could impact dementia or cognitive problems. And so everything has to be taken in context for what we're dealing with. But at the same time, quality of life is really tough on both the patient and the caregiver when you're in these situations. And so you do have to figure out, pros and cons of doing medicine or not. But there are other things like external catheters, there's definitely depends and briefs and diapers and things like that. There's systems sometimes that can wick urine away. I haven't seen a lot of those used, but I know they're out there. I don't know how expensive they are. But there are certain other things you can try, but it is a really hard problem and it is not an easy one to solve. Is there any association between Parkinson's disease and recurring hiccups? Not that I know of, although I'd have to look it up. I have had a couple of patients tell me about recurrent hiccups, but I don't know that I can necessarily say it's common enough that I think there's a correlation between that and Parkinson's disease. Because I've also seen people without Parkinson's disease have recurrent hiccups. And so, again, there are different centers of the brain that control things like hiccups, like vomiting, like, belching, things of that nature can come from brain issues, particularly in the brain stem or the near area. But I don't know that I've come across a study or something that suggested that there was a correlation with Parkinson's disease. Although, again, as you guys know, anything can be blamed. Parkinson's can do literally anything, and so I wouldn't be surprised if there is one. I don't think I would do anything different about it. I'm not sure how I would go about treating that necessarily. That's definitely a tough one. There probably are some medicines that we could try, but I have a feeling that the medicines we would try would be the ones that go against things like Parkinson's disease, and so I'd have to be very careful with that. But so at least to my knowledge, I'm not aware of a connection. But if you found a paper or a report or something that showed me a connection, I also wouldn't be that surprised. When I exercise, I traditionally do boxing and then yoga. During yoga, I tend to get a bad tremor in my leg. Is this common? Maybe. So both of those are good ideas, by the way. Again, exercise is a great idea. I love it. Yoga, and I am not a yoga expert by any means. I have attempted yoga on a very rare occasion, and it does not go well. So I am not the one who can really tell you all the ins and outs about yoga. My guess is it's the positioning in yoga that's leading to the tremor. Although, again, I'm not entirely sure. There are patients that I have that in certain postures and certain positions, they shake more. Plus, if you're relaxed or resting during whatever yoga move you're doing, your tremor should generally be a resting tremor, not an action tremor. So maybe that's more likely to bring it out. Or maybe you're putting a lot of pressure and it's really more of a muscular weakness type of tremor. Believe it or not, I think I was shaking when I did yoga too, and it didn't go well, but that's because I'm very unflexible and wasn't very strong in those positions. So there's probably a lot of reasons for it, but I'm not sure. But the short answer is that I think even if you're shaking, I would still keep doing it. Yoga is good exercise. It really works on balance. Boxing definitely works on the cardiovascular system. And my personal philosophy is that a combination of different types of exercise is probably the best plan. That's not proven. That's definitely made up by me. But I think what you're doing is a great job. I can't say that I know for sure why your tremor gets bad, but it's probably something along one of those reasons. In the gut-brain connection, does PS128 help? So PS128 is the probiotic that is advertised for people with Parkinson's disease. I don't know. I mean, I've had patients take it, maybe not as consistently as the website or the company would want you to do it, but I've had people take it. And again, it's really hard to measure. I'm not sure how long it's expected to have turnover of the gut bacteria. And in turn, I'm not sure how long it should take before you would notice a difference. Does it matter if you're early, moderate, or late disease? I would imagine, earlier would be better. And so all of these things probably play a role in whether or not you'll see benefit of something like that. And so I think there's too many variables to know for sure. Again, we are fairly confident in the gut-brain connection, in the gut bacteria and the Parkinson's relationship. And I don't think there's a lot of harm to probiotics, prebiotics, things like that. The data is iffy. I'm not going to lie. It's not great in my opinion. And so there's not enough data for me to say, yes, you should do this. But at the same time, I think there's enough science there that if you want to try it, you're more than welcome to. Again, I think more to come. I think the more we learn about this connection and the bacteria and things like that, hopefully we come up with a better strategy that we can use to our advantage. But for now, that's probably the best we have. Is there a difference between the way to treat irritable bowel syndrome in a quote unquote normal person versus a patient with Parkinson's disease? I'm not entirely sure about that. That would probably be a better question for the gastroenterologist. My first inclination would be to say no. I can't think of any treatments that I've seen for irritable bowel that I think would be necessarily bad in somebody with Parkinson's disease, like the dopamine blockers or maybe the antiemetics. The medicines that I've seen have really been more kind of modulators or more like chemotherapy type agents in the severe people, more the ulcerative colitis or Crohn's disease. I'm not sure what they're necessarily using in irritable bowel syndrome these days, but I can't say that I've seen anybody who I thought, oh, this doesn't seem like a very good idea because you have Parkinson's disease. And so again, I'm guessing on this one, but I'm not sure that there is, but that would probably be a much better question for the gastroenterologist who really takes care of these people or treats them, and see what they think. Do I know anything about involuntary butt muscle clenching that causes pain in the butt and legs and Parkinson's? Is there anything that can help with the pain and discomfort? I mean, I can make something up. I mean, at the end of the day, you definitely get stiff. So are these involuntary clenching really just a stiffness or a rigidity? Could it be a tremor? Could it be a direct Parkinson symptom? Maybe, in which case, maybe we need a little bit more medicine to see if we can loosen those muscles or relax. We also know that with Parkinson's disease, your posture's not correct and your mechanics aren't correct. So a lot of people end up with lower back problems. And if you have spinal stenosis or if you have a nerve root compression, that could also cause pain, more sciatic type problems or radicular type problems going down into your butt and down into your leg, sometimes both sides, usually one. In which case we need to go looking at your spine, do some physical therapy or potentially surgery if there's something compressing something. So I think that question needs a little bit more exploration. And really the answer to the last part of it, which is there anything that can help with the pain and discomfort, is answered by figuring out what the problem is. If it's a Parkinson's disease problem, then potentially adjusting the Parkinson's disease medicines, the dopaminergic medications might help. If it's more of a neuropathic type problem or a nerve pain problem, we would use things like gabapentin, Lyrica, Cymbalta, or potentially surgery or nerve block or injection or something like that. And so I think the answer to that question comes down to we need to figure out what the problem is, and that might dictate or lead to what the best way to treat it is. Speaking of, I've started to experience tingling and numbness in my feet. Is this a result or a symptom of Parkinson's disease? Well, it sounds more like neuropathy. Now, again, neuropathy is very common. Parkinson's disease is very common. So theoretically, common things being common, you can get both. There's no doubt about it. And traditionally, we don't think of numbness or neuropathy as a symptom of Parkinson's disease. However, in the studies where they were doing intestinal infusions of levodopa, i.e. the duopa or duodopa in Europe, they did find neuropathy was a side effect of the levodopa. It's not traditionally thought to be a side effect of regular Sinemet or the pills, but it seemed to be a side effect of a fairly good side effect to the intestinal infusion. And so I think there's probably some sort of correlation there. So could it be a result of Parkinson's disease or the treatments for Parkinson's disease? Maybe. However, neuropathy is also very common, and so it's hard to tell. Now, I wouldn't treat it any differently. If my patients came to me and said, hey, I'm having some numbness and tingling in my feet, I would do some blood work looking for vitamin levels. I might do an EMG, which is an electrical study. And if it became bothersome, then we still use medicines like gabapentin and Lyrica and amitriptyline and Cymbalta and all the neuromodulators. And I think I would use the same exact medicines in somebody just coming to me for neuropathy as I would in one of my Parkinson's disease coming to me with neuropathy symptoms. So I don't think my treatment strategy would be different, but that would be my thoughts on that. Again, we're talking about a lot of nerve problems here. Is rhizotomy recommended for people with Parkinson's disease? I wouldn't be against a rhizotomy in Parkinson's just because somebody has Parkinson's disease. I would be against a rhizotomy just for funsies, but at the end of the day, a rhizotomy is where you burn the nerve to try to help prevent the pain that either compression or irritation or inflammation of that nerve is causing. Again, usually more along the lines of neuropathic problems, spine problems, neck problems, back problems, so on and so forth. And if the pain specialist, who is usually the one who does a rhizotomy, thinks that this would help, I'm not against it. I don't think having Parkinson's disease would make me think, oh, this wouldn't be a very good idea, or no, you shouldn't do that. I think it makes sense that if that's what they think is the best treatment for your pain or whatever they're trying to accomplish, then I'd be okay with it. Now, I don't like giving direct care or direct information, but I'll answer this one. So long story short is they changed the timing of their Cinemet from 7 a.m. and 5 p.m. to 7 and 7, and they were doing worse. And well, the first thing I would do is say, well, if you're doing worse, go back to what you were doing. But it sounds like maybe there's some adjustments that might need to be made. Can't hardly walk by herself. Please advise. East Pittsburgh's tough. So actually, yeah, Dr. O'Black is out in East Pittsburgh somewhere. Greensburg, maybe. Casey, you know better than I do where he is. He'll be at the meeting next week too. He was actually a resident here, so I know him very well. He's very good, and he did a fellowship down in Texas and now came back. I believe he's out east, but the long story short is, yep, you probably need to find a movement disorder specialist near you who can get you in. And if you're out in East Pittsburgh, I want to say he's in Greensburg area or out in that direction. So Austin O'Black is a relatively newer movement disorder specialist out there. But if anytime I change a medicine in my patients and they call me up and say, hey, I'm doing worse, my first choice or my first inclination is to say, okay, undo what I just did and go back to what you were doing. And then we figure out another plan. Over time, I've noticed my head tilting slightly to one side. I also have been experiencing neck pain. Is this common with Parkinson's disease, and any suggestions on way to help with this? Yeah. So it depends on how it's turning. So I get a lot of people with head drop syndrome, which is exactly what it sounds like, which looks like this. And that is an extremely difficult problem to fix. I have not had good success with medications. Neck braces almost never work. They're only uncomfortable and they don't solve the problem. If it's being pulled down, you could think that Botox injections might be useful, but at the end of the day, you really hesitate to inject the front muscles because of swallowing dysfunction. And so again, if you're tilting to a side, maybe injections would be helpful. But again, this is one of those things where we're going to need more information. So the short answer is yes. I do get a lot of people who have a neck turn, and a lot of times this is thought of as a dystonic posture. Cervical dystonia is a standalone disease, but it can be part of Parkinson's disease too, and it's overactivity of the neck muscles, but not equally. So if your right-sided neck muscles are overactive, then more so than your left, you're going to get a turn or a tilt or something like that. And because it's usually overactivity of the neck muscles, then we can do Botox injections to try to help it. But again, when it's to the front, that's much more difficult. If it's something that comes and goes, and particularly if there's a pattern to it with the medicines, well, then maybe we need to adjust your medicines to see if we can account for that. If that's a wearing off phenomenon, maybe we need more. If it's a peak dose dystonia, then maybe we need less, or we need to spread them out a little bit more. And so if you can find any patterns to it, that might help. But invariably, anybody who comes in with neck turn, tilt, movement ends up with a lot of arthritis. They end up with a lot of neck pain, and it's tough. Again, sometimes physical therapy helps to strengthen those neck muscles and to try to work on keeping your posture correct, but that's a really hard problem. And again, I have not had success with a lot of braces or things like that. And so the best chance for that is really trying to figure out, is there a pattern to it? Is it a neck muscle firing problem, or is there a specific treatment for it? But that's going to be a tough one. I will have to check that out, Vicky and Donna. Had good success with Trazodone, old antidepressant, good for sleep. Yep, and I've used Trazodone in some people it works for, some people it doesn't. And just like everything else that I do in my office, and if you're my patient, you already know this, everything we do is trial and error. What works for one person does not work for another person. And what works for you or what you're experiencing is not exactly the same as somebody else. And even though I know people like to compare themselves to other people, especially in support groups or boxing classes or so on and so forth, you really have something different, and your constellation of symptoms or what you're experiencing is very different than what the person next to you is. And when you come to the office, we really try to tailor what we do to your specific problems. And so if I put you on Trazodone, but I put the next person on Klonopin, there was probably a reason for that. And it doesn't mean that they're better or different or worse than you. It's just that this is what we're going to try, and everything becomes a little bit of trial and error. When I potentially adjust the Cinemet at night due to having trouble sleeping, do I recommend extended release Cinemet versus regular? You will see me do that. I don't really like the Cinemet CR. It doesn't work as well as the immediate release does in my experience, but the one time I will use it is at nighttime or bedtime because I'm trying to get it to last a little bit longer. People don't necessarily need to feel it kick in when they're sleeping. They just need it to work longer. And so that is the one time I will use the extended release, but that's not to say you couldn't use the immediate release. I use a lot of both. And when you're trying to adjust for nighttime or sleeping, that again, it's a lot of trial and error, but yes, you will see me use the controlled release there more. There is actually. So why isn't there more of a focus on determining the origin of Parkinson's via the gut versus the brain? Perhaps if we knew where or why it originated, we can more accurately treat it. And you're absolutely correct. Again, you're right. A lot of the work is in genetics, but there's still people working on the gut. I mean, there are whole labs that are working on this. Again, it's just everything takes extremely long time. Nothing is nearly as efficient as it should be, and research that you think should be simple just isn't. And so there are people working on that, because you're absolutely correct. If we can figure out why people get it or where it comes from or what the underlying trigger is, we would be 15 steps in the right direction for trying to fix it. And so the short answer is there are people still working on this. It's just that research is really hard to do. It's really time consuming, and it takes forever. It is not quick. It is not a simple solution. It really takes a long time to do these things. And that's why you don't hear about them all that often. But trust me, there are people who are still working on that, I think, as far as I know, at least. And I'm hoping that they do give us some answers. Yes. So I know exercise is the best thing to do for Parkinson's disease, and that's because you've been listening to me talk for long enough. But just wondering if it uses up levodopa. And should you always try to exercise when you're on, not off, for it to be more effective? I don't know if it's ever been studied on versus off, or if it's more effective or less effective, but the short answer is yes, it can definitely in the short term use up your levodopa or make you worse. I have a lot of people that say, when I exercise, my shaking gets worse, my walking gets worse, at least in the short term. But the long-term benefits of it are so super important that we can always make up for, short-term problems by increasing medicine or doing more. And that's what I always tell my patients. Even if you feel worse, which most people feel better after exercise, but if you are one of the people who feels worse because your symptoms are worse, because you're burning up your dopamine or you're using up your levodopa, I would rather adjust your medicines and have you keep exercising, because the long-term benefits are so very important that you really have to keep doing it. And oftentimes we find, okay, we just take an extra pill before you go exercise, or we smooth things out. We can come up with a way to try to mitigate that. What are my thoughts on thyroplasty I honestly don't know. I've never been asked that question, nor have I ever come to it. I'm going to have to look that one up for you, because I don't know if there's any correlation that I need to be aware of or that I haven't read about. So I'm going to table that question here. I'm going to type it into my computer. And I'll get back to you next time, because that's not a question I've ever run into, and I honestly don't know the answer on that one. Do folks under 60 do better having DBS than older folks? I mean, I don't want to stereotype people here, but yes. And really, the reason isn't age. Age is just a number, but it just so happens that you accrue medical problems the older you get. I mean, that's just the way it works. Most people get more, it's not like medical problems ever disappear. You just kind of accrue more. It's like every time you go to a doctor, they give you another pill, right? The same idea. And obviously, less medical problems is better when you're undergoing a brain surgery. People do tend to have more frailty, more comorbid conditions the older they get. And so, I mean, the easy answer is to say yes. The younger you are, the better things are. That's not always the case. Believe me, I have some 90-year-olds that are probably healthier than I am. But in general, if I had to generalize, yes, younger might be a little bit better, but not because I think DBS works better or your brain is different or the symptoms are different. Mainly, I think that's because of the comorbid medical problems that come with aging, and the fact that you just tend to accrue more and more medical problems the older you get. That's really the only reason why I would answer it that way. Of course, I have thoughts on vitamin B1. I like that. Just thoughts on vitamin B1. So again, we've talked about B1 before. There's a lot of talk about vitamin B1 these days. In fact, Casey, you probably know more about it because the Parkinson's Foundation is actively involved in working on this. There is some data to suggest high doses of vitamin B1 is good for people with Parkinson's disease. This came out of an Italian group. There's a couple of papers on it. and there's a book about it. And I've had plenty of patients ask about it lately because the news keeps spreading, and I've had patients to go on high doses of vitamin B1 with some success. I have had patients, I always tell you that I will tell you when people come back and try supplements and vitamins and they do well. This is one of those cases. I have had several patients come back and be in the high dose vitamin B1. I won't call it a study, we'll just call it a group. And they do seem to be doing well. I have one guy in particular who really does well. He has really felt much better. And he was one who was on high doses and felt better and came back down off of it and felt worse and went back on high doses and felt better. And so I can't argue with the experience. Again, in order for me to recommend something, I need more actual evidence. I need more actual research studies, but this is a good start. And so my thoughts on vitamin B1 are it's promising. Perhaps it is helpful. If you want to try vitamin B1, go for it. The patient in question did run into some side effects when he got really super high on the vitamin B1. So there is a limit and there are potential complications, but you'll figure that out as you do it. But at the end of the day, if you're interested in doing it, go for it. I have not run into many problems with it. It's just that it is not quite proven yet, in my opinion. I need to see more good trials and more evidence to suggest that it really is beneficial before I can actually, quote unquote, recommend it. That's how I do things. And so those are my general thoughts on vitamin B1. I'm very interested when my patients do these things and they report back to me, especially when it's helping and working. And I will definitely tell you guys when it's working. And so far, the reports have been fairly good, but I still want to see how it goes and more to come on that. Interesting. My son, and so what do I got? A couple more questions. All right. There's no way to, I guess, cap it, Casey, but at the end of the day, I only got 3 minutes, so I'll do the best I can. My son is 43 and seeking treatment for restless leg syndrome, which is quite disruptive to him. His dad had Parkinsonism, died 5 years ago. Is there any screening for Parkinson's that my son should consider? Restless legs can be a precursor for Parkinson's disease, and many people with Parkinson's disease also have restless legs, although they can be two very distinct things. The short answer is maybe. And I say maybe, or I say yes and no for the obvious reasons. Yes, I mean, again, with a family history of Parkinson's disease, another potentially neurodegenerative condition like restless legs, you definitely got to treat it because it is very disruptive, but maybe there is a connection there. Maybe there is a genetic correlation between the two, and maybe he is somebody who is predisposed to develop Parkinsonism. Now, there's no test for this kind of thing. You can undergo genetic testing to see if you're a carrier or things like that, although it's very expensive, but there really is no predictive test for people with Parkinson's disease. If you're interested in doing the genetics or things like that, by all means, go for it. The downside is that even if at 43, I could say, yes, you are going to develop Parkinson's disease, my answer is going to be, you should exercise, which I'm going to tell you that anyway, even if you just come to me for restless legs or something completely not related, because I tell everybody that they should exercise because it's my favorite topic. And we're just going to watch because there aren't any things that we can do from a medication standpoint or from a treatment strategy standpoint that's going to change that course, that outcome. Exercise probably does. Now, you could argue again, B1 or these supplements, would they be reasonable? I don't know. There's not a lot of evidence. I can't say that for sure, but it's at least worth thinking about. But the short answer is even if I knew somebody was going to develop Parkinson's disease, there really isn't anything different that I would tell that person that I wouldn't tell them anyway, which is exercise and be as healthy as you can. I wouldn't start medicines. I wouldn't do anything differently really until they develop symptoms, and then it becomes how bothersome are there. So again, that's a double-edged sword. That information, am I going to develop Parkinson's disease, is helpful, but also potentially not helpful, right? And so that can go both directions. And so that's a subjective choice that you have to make. But I would argue that even if I knew the answer to that question, it wouldn't change my recommendation. Is there any benefit to Parkinson's from the use of medical marijuana? Well, I happen to be a certifier of medical marijuana. I have been relatively from the beginning. I forget how many years it's been, and I've certified quite a few people with Parkinson's disease for medical marijuana. So does that mean I think it's good for people with Parkinson's disease? Yes and no. My experience, and there's not a lot of studies on medical marijuana either. There's not a lot of good evidence out there. In fact, I don't think there's any good evidence out there for medical marijuana and Parkinson's disease. And the main reason for that is marijuana is still federally a Schedule I drug, which means it's very illegal, ranks up there with heroin and LSD. Hard to research. My experience, on the other hand, has been mixed. So the things that I've had success with medical marijuana fall into 3 categories: anxiety, sleep, and pain. I have not had, although with the exception of one person who comes to mind who really did think that it helped his straight Parkinson's symptoms, I have not had a lot of success with things like tremors and stiffness and slowness of movement or balance problems. But everybody on the call here or on the phone here, video here, knows that when they're anxious or when they don't sleep very well or when they're in a lot of pain, their physical symptoms get worse. And so those are the things that I've had some success with medical marijuana. Not a lot, not everybody likes it, but some people have found some benefit. And then secondarily, if I can treat pain or sleep or anxiety, secondarily, the tremors and the stiffness and the other symptoms seem to be better. That's been my experience over the past 6 or 7 years or however long it's been that I've been doing it. It's not a cure-all. It definitely doesn't fix everything. It's not a miracle, but it does help somebody and the right patient with the right symptoms. We do use it. I'm not entirely sure what's considered high dose B1. There is a book and a paper about that. And so that would really, you'd have to look at the paper. Actually, probably 90% of the people on this video know better than I do what high dose B1 is. They could probably tell you or type it in the chat box. I'm not sure of the exact numbers. Yes, I'm still going to check out that podcast. And then my last question will be thoughts on CBD. I take it the federal government has had a patent on cannabis as a neuroprotectant for years. They probably have. Again, it's all about money, as you know. My thoughts on CBD, and this will be the last question, are really similar to my thoughts on medical marijuana, except I've actually had less success with CBD, with the exception of one thing: pain. So the CBD creams, I've had some patients have success with pain, and they like it because it's not a tincture, it's not a pill, it doesn't make them high or anything like that. Whereas the medical marijuana does have a component of THC in it, which is the component that makes you high. I've had occasional patients find benefit to the CBD cream, rubbing it on joints or things like that for pain. But outside of that, I really have not had a lot of success with the CBD component containing compounds. Really, the medical marijuana that has some of the THC in it has been the better of the two in my experience. But again, coming back to those same things like pain, anxiety, and sleep. And so those are really the things that I have found to maybe have some impact or some benefit. And those are the patients that will talk about it or think about using it. And with that, Casey, I will send it back to you. And we'll do it again. Actually, in a week or so at the conference, I'll be there doing something similar, but otherwise we'll do this again next month.
Thank you, Dr. Leichliter. I hope to see a lot of you at the conference next Saturday, April 13th. If you didn't sign up, contact me, please. And
Thank
we'll see you
you.
on May 2nd for the
Casey,
next talk with the
Casey,
doc. Thank you,
Casey,
everybody.
I have a question,
Thank you,
please.
doctor.
Oh,
Thank you. Bye.
bye.